Ketamine is an NMDA receptor antagonist. At high doses, it also affects many different neurotransmitter receptors. So it has a multimodal properties. Ketamine produces a dissociative stereotypy, and at especially low doses, it can produce a sedation and analgesia. That's why it is also called a trauma analgesic and very popular in military personnel as well. And ketamine can also produce antidepressant effects at lower doses. We also found that ketamine can produce anti-inflammatory effects and stimulate HPA axis, a stress pathway. So let me talk about translational research of ketamine related to psychiatric disorders. And we established a method of delivering intravenous ketamine in awake and freely moving rats, because that is a clinically relevant way of administering ketamine in animals and then looking at various effects of ketamine. So at the end of my presentation, I'd like to convince you that ketamine can, depending on the dose or route of administration, can produce opposite effects on specific outcome variables. So I have nothing to disclose, and these opinions are mine. It doesn't reflect my university. As I mentioned, the ketamine is a non-competitive NMDA receptor antagonist. It has a anesthetic effect at high doses, and it produces analgesic effects at lower doses. However, role of post-trauma ketamine administration on neuropsychiatric symptoms, such as a post-traumatic stress disorder or traumatic brain injury, are not well understood. As you know, traumatic brain injury is a major cause of death and disability worldwide, and millions of people are affected by TBI every year. But majority of TBI is considered as a mild TBI. So more than 80% of TBI patients are suffering from mild TBI. However, even mild TBI can result in long-term disability, including physical, cognitive, emotional, social, and behavioral deficit. Unfortunately, there's no consensus on evidence-based treatment for TBI, including mild TBI. So it is a great public health problem. This shows a potential biological mechanism of ketamine. On the top here, it shows hypothalamus, pituitary, and adrenal gland HPA axis. And when we inject the ketamine, we can see stress hormone level elevation, especially corticosterone in rodents. And then, so that can be a potential mechanism for stress-related responses of ketamine. And this one shows more like a molecular aspect of ketamine action. Ketamine can block NMDA receptors, and depending on where those receptors are located, it could actually increase glutamate release by inhibiting inhibitory GABA neuron here. And then glutamate release can further stimulate postsynaptic neurons, as shown here. And BDNF, brain-derived neurotropic factor, can be released by ketamine, and that can also contribute to postsynaptic mechanisms. And those intracellular molecules can be affected, and finally, it can produce like functional effects on like fear and stress-related behaviors. So this is a ketamine. As I just told you, ketamine has many different effects. That's why it's called a multimodal dissociative anesthetic. And usually it is administered by first responders to treat traumatically injured patients. It is safer than opioids due to hemodynamic stability and preservation of respiration. So it has a really high safety property. But ketamine has some side effects, including dissociation, hallucination, and even abuse potential. And the best way to deliver ketamine is through intravenous route in patients. Ketamine is a popular battlefield analgesic in military populations for the reasons I just told you. Also, there is a growing interest in ketamine in neuropsychiatric disorders, including post-traumatic stress disorder and TBI symptoms. So let me skip this. So this is the first paper we published using intravenous ketamine infusion in freely moving rats. So we did a very thorough characterization of intravenous ketamine. So we looked at the various outcomes after giving ketamine in rats. So usually clinicians administer sub-anesthetic dose of ketamine to treat major depression, pain, and PTSD in humans. However, in animal studies, ketamine is usually injected through intraperitoneal route, usually with higher doses. So it's difficult to compare results from animal studies and human studies. So we developed a way to deliver intravenous ketamine in rats, and then we studied the different outcome variables: dissociative stereotypy, locomotor activity, sensory motor gating, and thermal nociception, which means like analgesia. So this shows analgesic effect of IV ketamine. Left side shows a bolus ketamine effect. Right side shows a ketamine infusion effect. After bolus ketamine administration, either 2 or 5 milligram per kilogram, we can see increased analgesic effect measured by heart rate latency in rats. And with high dose ketamine, effects can last up to 50 minutes. With the continuous infusion, of course, analgesic effects can last even longer. So we tested different doses of ketamine infusion, and with the high dose ketamine infusion, analgesic effects can last up to 120 minutes. So there was a difference between bolus and continuous ketamine infusion on analgesic effects. Here, I'm trying to show you dose-dependent effect of ketamine on locomotor activity. The ketamine can produce either sedation or stimulation, mainly due to dissociative stereotypy, depending on doses. So we tested general locomotor activity, and these are different doses of ketamine. 5 milligram per kilogram ketamine infusion reduced activity due to sedation. So animals became a little calmer, and then just simply they became slightly sedated. But when we increase the doses, especially at 20 milligram per kilogram infusion, animals became dissociated. So they are actually showing greater activity. And then this one shows just a time course of the same data. You can see over 60-minute time period, low dose reduced activity compared to control group, and high dose ketamine stimulated activity. And we also looked at acoustic startle reflex and pre-pulse inhibition as a measure of sensory motor gating, and we found a high dose of ketamine reduced the sensory motor function as well as a pre-pulse inhibition, which is a sensory gating mechanism in the brain. So it really shows a dose-dependent effect. So we were also interested in ketamine effect on stress hormone levels. So we looked at corticosterone, which is a stress hormone in rodent. So you can see pretty much we are like saying same rationale in each study. Like post-trauma anesthetic agent may influence neuroendocrine responses that may affect traumatic memory consolidation. However, effects of sub-anesthetic intravenous ketamine infusion on the mediators of traumatic stress in rodents are largely unknown. So we used the intravenous ketamine infusion following rodent fear conditioning paradigm, which uses paired auditory tone, which is a conditioned stimulus, and the electric foot shock as an unconditioned stimulus to produce a fear memory in rodents. And then we measure the stress hormone levels in male Sprague Dawley rats. I'm sorry for the little blurry image here, but what we found was ketamine infusion increased stress hormone levels in rats, and it was dose dependent. And left side shows the experiment without fear conditioning. Right side shows the experiment with fear conditioning. There was no clear difference between no fear conditioning or fear conditioning studies, which means fear conditioning per se didn't really elevate court levels here. But ketamine infusion clearly elevated court levels. It was a dose-dependent effect compared to 20 milligram per kilogram elevated court levels, even greater. So 2-hour time point means immediately after IV ketamine infusion. 4-hour time point means 2 hours after ketamine infusion. So as you can see, court elevation is transient. So after elevation, usually levels come down relatively quickly. That's why we see actually reduction 2 hours after. So since ketamine can stimulate HPA axis, we looked at ketamine effect on fear memory using Pavlovian fear conditioning in rats. As I mentioned before, ketamine is given after traumatic injury and traumatic stress and traumatic injury. Therefore, there may be a chance of enhancing traumatic memory consolidation due to dissociative properties of ketamine. So we were interested in whether post-trauma ketamine administration will enhance or reduce the traumatic memory consolidation and expression in animals. So that was the rationale of the study. This one shows IV ketamine infusion effect on fear memory. So what we did was we did a fear conditioning experiment and then delivered IV ketamine infusion. And 2 days later, we looked at fear memory in rats by measuring freezing behavior in animals. So y-axis shows percent freezing, x-axis shows repeated presentation of auditory tone, which is a conditioned stimulus. So here what's happening is if we keep playing conditioned stimulus, then animals will show fear behavior eventually, but they will start to learn, okay, there's no foot shot, so they are learning to extinguish fear memory. That's why we see fear extinction pattern in this graph in control rats, but in animals that receive the ketamine infusion right after fear conditioning, they actually show the enhanced fear by showing increased freezing. So there was a enhanced fear and delayed fear extinction. And we repeat the same test on day 3 to make sure, we are seeing, fear extinction behavior. And then day 4, we looked at fear memory recall by putting animals back to the fear conditioning chamber and looked at contextual fear as well as acute fear. And these graphs are just total freezing behavior for the same data. So this one shows area under the curve. So measuring just area under the curve, and then we are seeing inverted U shape, which means the medium dose 10 milligram per kilogram ketamine significantly increased the fear memory, but not low or high dose of ketamine. So that was a bit surprising to us, actually. And then in this study, we compared a different route of ketamine administration, which was injection. So this was a continuous intravenous ketamine infusion, and this one was intraperitoneal ketamine injection, and then we repeated the same experiment. So this was done with a 10 milligram per kilogram ketamine injection. But here, actually, we saw facilitate the fear extinction rather than delay the fear extinction. So with the ketamine injection, we didn't see enhanced fear memory or delayed fear extinction. Rather, we saw facilitated fear extinction, shown in this graph as well as here, as the area under the curve. So these data really represent, depending on the route of ketamine administration, either intravenous infusion or bolus injection, same dose can produce opposite effect on fear memory. So let me quickly just go over some TBI studies we did with IV ketamine. As you know, TBI is a main public health problem worldwide, and most of the TBI cases are mild TBI. However, even mild TBI can produce long-term physical, cognitive, emotional, social, and behavioral deficits in certain individuals, not everyone, but certain individuals. So the way we study mild TBI in animals is actually using a paradigm called the chimera. There are different types of brain injury. This is a direct impact injury. This is an acceleration, deceleration injury, like brain shaking. And this one is a shock wave injury, like a blast injury, very frequent in a military population. But we are mainly focusing on these two types of injuries using our animal model, which I will show you quickly. And then this one shows how actually we use indwelling jugular vein catheter in rats. We can implant a catheter to a jugular vein, and then we can deliver intravenous ketamine in freely moving rats, as well as drawing blood. Using same jugular vein catheter, we can sample blood at different time points and use for blood assays. So it's a great way of studying effect of ketamine. So this is a paper we published recently looking at ketamine effect on mild TBI. So that was the animal model we used. It's called the closed head impact model of engineered rotational acceleration, chimera, to study mild TBI. So this is a device. Animal can simply lie down on the platform, and there's a piston operated by gas tank. So we can adjust the force or impact of injury directly applied to the head. And we can also deliver multiple injuries in a same session. So that is the model we used. That was a study design. So we did the chimera injury first, and then performed the ketamine infusion, and we looked at different behavioral outcome variables, like locomotor activity, rotor rod performance for motor balance function, as well as acoustic startle and pre-pulse inhibition. And we also looked at brain pathology at the end of the experiment. So let me quickly show you some of the results we found. So this one shows microglial activation after chimera injury. microglia can change morphology depending on the injury. So these like round shapes are activated microglia, unramified. So these are activated ones, but these are ramified or inactive microglia. So after injury, usually microglia become like this. And then this is a cortical area of a chimera injury, and we clearly see microglial activation. So you can see like zoomed in images here. So those are activated microglia in this region, but the other areas, a little bit like a distal region from the injury, we see inactive microglia. So that was a good evidence of chimera injury. And this is a axonal injury after chimera injury, axonal injury after chimera. So in the optic tract, so that is in the white matter, a little bit like a subcortical area, but we still see clear axonal damage after chimera injury. So these are nice evidences of, in a way, mild TBI after chimera. And ketamine infusion like reduce some of the inflammatory cytokines, but there was also dose and time dependent. Especially we found the KCGRO. This is one of the chemokines, and like TNF alpha and IL-1 beta. These cytokines or chemokines were generally reduced after ketamine infusion, but it was rather transient. It didn't last very long. So this is the overall hypothesis that we are thinking. After TBI, there will be a secondary injury like the neuroinflammatory cascade that can contribute to neuroinflammation and the functional deficits. And ketamine may prevent neuroinflammation, and therefore there may be some like beneficial effects on mild TBI. So that's the general like a hypothesis we are formulating. And this one is another way of looking at potential ketamine effects on neuropsychiatric disorders. Ketamine can affect like stress responses and injury.
Sorry, but we have to finish until 3 p.m. So.
Okay. So let me just finish with the conclusion. So we established a clinically relevant intravenous ketamine infusion paradigm in rats. And we found several factors, including route, dose, and timing of ketamine infusion. Ketamine administration is very important. And we also found sex is an important factor in ketamine study, which means we found a differential effect between male and female rats. So better understanding of biological mechanisms of ketamine may improve a translation between preclinical and clinical research. So I'll skip that. And I'd like to acknowledge my lab members and our funding source. And thank you for your attention.